everyone, welcome back to my channel. I've started revising for my Mrcp part 1 exam and I thought I'll take you guys along with myself. So I've started reading this book, Khalid Maghrabi, for Mrcp notes, and I've started with the cardiology section because that is the most important and a lot of questions are there from cardiology. So let's begin, guys, without wasting any much time. So the first topic we have is the long QT syndrome. It is an inherited condition associated with delayed repolarization of the ventricles. It is important to recognize that it may lead to VT and can therefore cause collapse, sudden death. See, when we are practicing also, we usually keep an eye on the QT prolongation on the ECGs because we want to avoid the drugs that are given over here so that the patient doesn't land up in a VT. So that's why long QT syndrome is very important to see, and the patient doesn't land up in a VT. The most common variant of long QT syndromes are long QT syndrome 1 and 2 and are caused by defects in the alpha subunit of a slow delayed rectifier potassium channel. This is what we need to remember, the potassium channel from Q and K. This is how we can remember. A normal corrected QT interval is less than 430 milliseconds in males and 450 milliseconds in females. So you need to keep this value in mind, 430 and 450 for males and in females. The normal range for duration of a corrected QT interval is 350 to 430. Sorry. This value is also very important. So this table that comes after is very important because this is the causes of a prolonged QT syndrome. The first one given here is the congenital. Congenital we have only 1 and 2. First one is Jervell-Lange-Nielsen. JLN syndrome includes deafness. So this Jervell will not listen and is due to abnormal potassium channel. Again, this potassium channel is what we are talking about. And Romanov-Ward syndrome is no deafness because in a ward there is no deafness. The drugs that we need to keep in mind is amiodarone, sotalol, then class 1 antiarrhythmic drugs. These belong to all antiarrhythmic drugs. Tricyclic antidepressants and SSRIs are antipsychotic drugs, including lithium, also chloroquine, mefloquine, terfenadine, and terfenadine is antifungal, and macrolide, erythromycin, clarithromycin, levofloxacin are antibiotics, domperidone, ketoconazole, haloperidol, tacrolimus. So whenever you see a patient with a QT prolongation, we usually avoid these antibiotics. We see that we don't give them all these antipsychotics, and we keep an eye on the antibiotics that we are giving them. Also, we need to keep the electrolytes in the range because they are frequently either they are hypokalemic or hypomagnesium, so we give them a potassium correction or we give them a magnesium correction. They also have acute MI, myocarditis, HOCM, hypothermia, subarachnoid hemorrhage, and hypothyroidism. Now coming to the next part is Jervell-Lange-Nielsen syndrome is caused by mutation in the KCNE1 and KCNQ1 genes. K stands for this potassium only. The KCNE1 and KCNQ genes provide instructions for making protein that work together to form a channel across cell membrane. These channels transport potassium-charged potassium atoms out of the cell. So you need to remember this part, potassium atoms out of the cell. The movement of potassium ions through these channels is critical for maintaining a normal function of inner ears and cardiac muscle. That's why the patient was deaf in the JLN syndrome. Okay, the features may be picked up on a routine ECG or following family screening. Long QT1 usually associated with exertion syncope, often swimming. Long QT2 often associated with syncope occurring following emotional stress, exercise, auditory stimuli, doorbell or telephone ring. Long QT3 events occur at night or at rest. So this one is during swimming, this one is during emotion, and this one is during at night. This can also result in sudden cardiac death. Diagnosis based on the long QTC corrected QTC interval, although this may be within the normal range at rest. Hence, Holter ECG monitoring is recommended. Identification of a long QTS genetic mutation confirms the diagnosis. However, negative result on genetic testing is of limited diagnostic value because only approximately 50% of the patient with long QTS have known mutation. The remaining half patient with long QTS may have mutation yet unknown gene. That's why we usually do not do this genetic mutation test, although this is a confirmatory test. Therefore, genetic testing of long QT syndrome high specificity but low sensitivity. That's why it's not done routinely. Also, what we do is we do an ECG and we do a Holter. That's why we stop our investigation. And once the patient is labeled as a long QT syndrome, we just try to keep in mind that the above drugs are not given to him. This ECG shows a long QT and ventricular premature beats. The loss of consciousness may have been due to ventricular arrhythmia, in particular torsade dispointes VT. Now, management is first is to avoid the drug with prolonged QT interval and other precipitants if appropriate, like a strenuous exercise. Beta blockers has to be given. Then propranolol, metoprolol, atenolol, not sotalol. You have to remember this part, not sotalol. ICD is implantable cardioverter defibrillator in high risk cases. That is, it is only required in high risk cases. For example, if the patient has QTC more than 500 milliseconds, the previous episode of cardiac arrest, left stellate cardiac ganglionectomy. This is also rarely done. Long QT syndrome usually due to loss of functioning, blockade of the potassium cells. This is very important. We have to remember long QT syndrome is because of the loss of function of potassium channels. Note, beta blockers are the mainstay of therapy, asymptomatic as well as symptomatic patients with idiopathic long QT syndrome. Beta blockers decrease sympathetic activation from the left stellate ganglion, also decrease the maximal heart rate achieved during exertion, and thereby prevent exercise-related arrhythmic events that occur in the long QT syndrome. That's why they have explained why beta blockers are the treatment in the long QT syndrome. Patient who experience ventricular arrhythmia, aborted sudden cardiac despite beta blocker therapy should have an ICD in addition to a beta blocker. If they have aborted sudden cardiac death, then ICD is a must. Left stellate cardiac ganglionectomy is an invasive procedure, results in Horner syndrome. It is where one eye is big, one eye is small. It is performed in patients who have symptoms despite beta blocker and have frequent shocks on the ICD. Non-sedating antihistamine classic cause of prolonged QT in a patient, especially if taking P450 enzyme inhibitor. Example, a patient with cold takes terfenadine and erythromycin at the same time. Terfenadine and erythromycin should not be given at the same time. Sotalol may exacerbate long QT syndrome due to blockage of the potassium channel. It leads to risk of ventricular arrhythmia. This can be particular is an individual with hypokalemia. So in sotalol, you have to remember the patient can have hypokalemia. So sotalol is better to be avoided in patient with thiazide diuretics because thiazide cause hypokalemia. Example, a 75-year-old male with history of anti-MI is taking amiodarone 400 mg per day for a history of VT, has prolonged QTC interval on his ECG of 550 milliseconds. The most appropriate management is to stop amiodarone immediately and can replace it with atenolol 50 mg because his QT is 550 and amiodarone is already it causes long QT syndrome. Management of drug-induced long QT syndrome: stop the drug, correct the electrolyte disturbance, and treatment of associated ventricular arrhythmia. First line drug of drug-induced long QT syndrome: IV magnesium 2 gram as a bolus, which is called magnesium shots. That's usually we give a magnesium shot followed by another bolus in 15 minutes if required, and continuous infusion at the rate of 5 to 20 mg per minute. QT shortening. Now we were studying long QT, now is short QT caused by everything is hypercalcemia, hypermagnesemia, digoxin, theratoxicosis. Torsade, coming to the next topic, torsade depointis. Torsade depointis is when the rhythm goes like this, like this, like this, like this. Is twisting around a point is the actual meaning of this word. Torsade depointis, twisting of the points, is a rare arrhythmia associated with long QT syndrome. It may deteriorate into ventricular fibrillation because this will turn into this and this will turn into ventricular fibrillation and hence lead to sudden death. Cause of long QT interval. Risk factor: female sex, prolonged QT interval, bradycardia, hypokalemia, severe hypomagnesemia, severe alkalosis, congestive heart failure, digitalis toxicity, recent conversion of AF. Management is IV magnesium, like a shot, magnesium shot. Magnesium, what it does, it decreases the calcium influx, reducing the amplitude of the VT and helping terminate runs of torsade. It is effective even when serum magnesium level is normal. Even when the magnesium is normal on the charts, don't hesitate to give magnesium for a patient with VT or torsades. Don't check the potassium, just give the magnesium shot whenever you see there's a VT or torsades. Ventricular tachycardia management. While a broad complex tachycardia may result from supraventricular tachycardia with aberrant conduction, a European Resuscitation Council advised that in peri-arrest situation, it is ultimately ventricular aneurysm. VT is a broad complex tachycardia originating from a ventricular ectopic focus. It has the potential to precipitate ventricular fibrillation and hence requires urgent treatment because VF will result in a sudden cardiac death. Therefore, urgent treatment is required. There are two main types of VT: monomorphic, most commonly called myocardial infarction, and polymorphic, a subtype of polymorphic VT, which is torsade disappointed, which is precipitated by prolongation of QT interval. Now, the management again would be the patient adverse signs like BP, low chest pain, if their heart failure rate more than 150, then immediate cardioversion. Cardioversion in short means you give the shock. You give the shock to the patient through these paddles on the chest of the patient. Okay. In the absence of such signs, the antiarrhythmics may be used. If these fail, then electrical cardioversion may be needed by synchronized DC shocks. VT with pulse not responding to medical treatment is cardioversion synchronized. Pulseless VT or VF is asynchronized because in VF there would be no QRS complexes to synchronize. That's why VT or VF DC is asynchronized. Drug therapy is amiodarone highly administered to central line 300 mg over the first hour, then 900 over the next 23 hours. Lidocaine used with caution in severe left ventricular impairment as it is negative inotropic drug. Procainamide. Verapamil should not be used in a VT because it is a calcium channel blocker. If drug therapy fails, we do the electrophysiological study like EP study or implantable cardioverter defibrillator. This is particularly indicated patients significantly impaired LV function. Hypokalemia is the most important cause of VT, clinically followed by hypomagnesemia. Severe hyperkalemia may cause VT certain circumstances, for example in patient with structural heart disease, but it is not as common for a cause as hypomagnesemia. Excuse me. The 2010 ALS guidelines state the patient has a monitored and witnessed VF pulses VTS in hospital. 3 quick successive stacked shock 200 joules should be given. Chest compression should be started immediately after the third with the compression to ventilation of 34:2 for 2 minutes. A precaudal thumb can be successfully gained within seconds of the onset of a shockable rhythm. Delivery should not delay calling for help or assessing a defibrillator, but would be indicated here whilst awaiting a defibrillator. Chest compression should start immediately if it's unsuccessful. You have to give IV adrenaline every 3 to 5 minutes. Once chest compressions have started, then you give defibrillation 3 times. If defibrillation for the third time without return of cardiac output, CPR is immediately resumed and adrenaline is administered. This and this you have to keep on giving. The next step is amiodarone 300 mg IV given after the third shock. If amiodarone is not available, lidocaine is suitable alternative. The new guidelines state there is no need for 3 successive shocks, only 1 shock followed by immediate chest compression and then reassess the pulse and rhythm after finish of cycle. So now you have to give only 1 shock, then continue chest compression for 2 minutes. You don't have to give 3 shocks. Pulseless VT with severe hypothermia. You have to give DC shock or medication will be ineffective. So better to start with prolonged CPR firstly till temperature can reach more than 30 degrees. If a pulseless VT with severe hypothermia is there, you have to give a CPR and give a DC shock. These 2 things you have to do. Hypothermic patient do not respond well to shocks or drugs, and there is no response to the first 3 shocks. Patient should be rewarmed for at least 30 degrees before any drug or shock administered. PVCs to be significant. PVCs. This ventricular complex, premature ventricular complexes have to meet the following criteria: more than 6 days per minute. PVC is bigeminal or trigeminal with short runs of VT, exhibit an R on T phenomenon associated with serious organic heart disease or LV decompensation. Then the PVC is significant, otherwise you don't have to take it seriously. Cardiac enzyme and protein markers. Myoglobin is the first to rise as early as 1 hour of MI within first 2 hours. Peak in the 6 to 8 hours, return normal in 24 hours. CKMB is useful to look for reinfarction. as it returns to normal after 2 to 3 days. Troponin T remains elevated up to 10 days. GPBB, glycogen phosphorylase isoenzyme. BB is an isoenzyme of glycogen phosphorylase which exists in cardiac muscle. By 3 hours post-myocardial infarction, it has risen significantly. As such, it is an appropriate marker for early cardiac muscle injury. So here they have spoken about 3: myoglobulin, CKMB and GPBB. Out of these, what we do is the troponin, or sometimes we do CKMB also. Myoglobulin we usually don't do. Now begin to rise, peak value, return to normal. Myoglobulin is the first 1 to 2 hours immediately, and then 6 to 8 hours, and then returns normal 1 to 2 days. Then the second one is CKMB, 16 to 20 hours, it maintains the peak and return to 2 to 3 days. CK, 4 to 8 hours, 6 to 24 hours, 3 to 4 days. Trop T, 4 to 6 hours, 12 to 24 hours, 7 to 10 days, my god. AST, 12 to 24 hours, 36 to 48 hours, 3 to 4 days. LDH, troponin is a component of thin filaments along with actin, tropomyosin, and the protein to which calcium binds to accomplish this regulation. We usually measure the trop-I. Trop-I is usually what is done in the hospital, and trop-I is thin filament along with actin and tropomyosin, and it is a protein to which calcium binds to accomplish this regulation. The other component of thin filament are actin and tropomyosin. Thick filament are primarily composed of myosin. Troponin has 3 subunits: troponin C, I, and T. When calcium is bound to specific sites on troponin C, the structure of the thin filament changes in such a manner that myosin attaches to thin filament and produces force and movement. In the absence of calcium, tropomyosin interferes with this action of myosin and therefore muscles remains relaxed. Troponin T, it is T because it binds to tropomyosin, which is a protein which regulates actin. It associates with actin muscle fibers and regulates muscle contraction by regulating the binding myosin. Troponin assay at 3 and 6 hours is adequate to determine whether myocardial damage has occurred. Now, MI is not the only reason for the patient to have elevated troponin. It is raised also in trauma, cardioversion. There was a trauma, there was a cardioversion, and there was a rhabdomyolysis, pulmonary embolism leading to pulmonary hypertension and hypotension, especially arrhythmias, HOCM, myocarditis, sepsis and burns, subarachnoid hemorrhage, infiltrative aortic disease including sarcoidosis, amyloidosis, hemochromatosis, and scleroderma, drugs including adriamycin, herceptin, 5-fluorouracil. Now coming to the next topic, hypertrophic obstructive cardiomyopathy. It was even autosomal dominant disorder of muscle tissue caused by defects in gene encoding contractile proteins. The most common defects involve a mutation in gene encoding beta-myosin heavy chain protein or myosin binding protein C. Mutation to various proteins include alpha-tropomyosin and troponin T have been identified. The estimated prevalence is 1 in 500, very much. HOCM is the most common cause of sudden cardiac death in the young. That's why we take a proper history when we take a history, and we ask a lot of questions if there has been a sudden cardiac death in the family. The history of sudden arrhythmias and death in young previously well individually suggestive HOCM relatives should be screened for it. Other features are like they are asymptomatic, but they sometimes have dyspnea, angina, syncope, and palpitation. There is sudden death, commonly due to ventricular arrhythmias, heart failure, jerky pulse, large air waves. There is a double apex beat. Ejection systolic murmur increases Valsalva maneuver and decreases squatting. Associations with Friedreich's ataxia and Wolff-Parkinson-White syndrome. Econemonic is MR, SAM, and ASH. They have MR, mitral regurgitation, systolic anterior motion of the anterior mitral wall leaflet. ASH is asymmetric hypertrophy, concentric hypertrophy, and dilated LV, increased septal versus LV wall diameter of ratio more than 1.3:1. This is asymmetric, that's why. ECG will show RBBB, prolonged PR, non-specific T-wave abnormalities, LVH obviously, Deep Q as in anterolateral and failures. AF may be occasionally C. Cardiac catheterization. Left ventricular pressure are high with steep drop off between the LV and aortic pressures. Poor prognostic factors include if they have a syncope, if they are young at presentation, family history of HCM and sudden cardiac death, non-sustained ventricular tachycardia at 24 to 48 hours of Holter monitoring, abnormal BP changes in exercise, drop of BP during peak exercise or stress testing, increased septal wall thickening more than 3 cm, septal hypertrophy causes left ventricular outflow tract LVOT obstruction. It is important cause of sudden death in apparently healthy individual. Management A, B, C, D, amiodarone beta blocker is usually what we prefer when we see HCM patient. We make sure that the patient is a beta blocker. Cardioverter defibrillator ICD implantation for such patient, or dual chamber pacemaker and endocarditis prophylaxis. Reducing outflow tract obstruction with myomectomy or alcohol septal elimination does not reduce the risk of SAD, but is usually recommended, especially when the outflow gradient greater than 50, particularly if symptoms of dyspnea persist post blockade. Drugs to avoid: no nitrates, no NAC inhibitor, no inotropes. Verapamil should, however, be avoided in HCM patient with coexistent Wolff-Parkinson-White as it will precipitate VT or VF. Most cardiologists would now proceed to insert ICD at lower risk to lower the risk of SCD. Example, patient of HCM with palpitations, the 24-hour ECG reveals runs of non-sustained VT. Best is the ICD. Most common cause of sudden cardiac death is HCM, more common cause of sudden cardiac death than arrhythmogenic right ventricular dysplasia. Estimated prevalence is 1 in 500. ARVC, arrhythmogenic right ventricular cardiomyopathy, the second most common cause of sudden cardiac death in the young after HCM. CPVT, catecholinergic polymorphic ventricular tachycardia, is a form of inherited cardiac disease. It is inherited autosomal dominant fashion. Prevalence of around 1 to 10,000. Brugada syndrome. Brugada syndrome is very, very bad syndrome. The form of inherited cardiovascular disease. It is inherited in an autosomal dominant fashion and has an estimated prevalence of 1 to 5,000. Brugada syndrome is more common in Asians. That's why we see it a lot. Screening of HCM. Current guidelines suggest that the resting ECG, like in asymptomatic individuals or something, and TTE, transthoracic echo, are the most effective screening strategy for relatives of patients with HCM. Genetic testing is not recommended. We usually don't do genetic testing. We only do ECG and TTE. First line screening tool to varying rates and penetrance. Okay guys, that's all for today. We'll meet you in the next video that I will make, continuing the topics that I'll be learning for as a part of revision of my MRCP exam. Thank you guys.